Chapter 1. Understanding Renal Anemia. Renal anemia is a common and significant complication of chronic kidney disease, CKD, affecting millions of individuals worldwide. It is characterized by a reduction in red blood cell count in hemoglobin levels, primarily due to the kidney's decreased ability to produce erythropoietin, EPO, a hormone critical for red blood cell production in the bone marrow. As kidney function declines, the synthesis of EPO diminishes, leading to insufficient stimulation of erythropoiesis and, consequently, anemia. The classification of renal anemia falls under the broader category of normocytic, normachromic anemia, indicating that the red blood cells are typically of normal size and hemoglobin content, but their numbers are reduced. This type of anemia often develops insidiously and becomes more pronounced as CKD progresses from stage 3 to stages 4 and 5. In end-stage renal disease, ESRD, renal anemia becomes nearly universal among patients, necessitating targeted intervention and long-term management. Epidemiologically, renal anemia is prevalent in over 90% of patients undergoing dialysis and affects a significant portion of individuals with moderate to severe CKD who are not yet on dialysis. It contributes to a variety of adverse clinical outcomes, including reduced exercise capacity, cognitive impairment, left ventricular hypertrophy, and increased mortality. The burden of renal anemia also extends beyond clinical complications, with patients often reporting debilitating fatigue, decreased productivity, and a diminished quality of life. Pathophysiologically, renal anemia is multifactorial. While the deficiency of erythropoietin remains the central mechanism, other contributing factors include iron deficiency, both absolute and functional, chronic inflammation, uremic toxins, and shortened red blood cell lifespan. These mechanisms interact in a complex way, often complicating diagnosis and treatment. For example, inflammation common in CKD can interfere with iron metabolism, reducing the availability of iron for red blood cell production despite adequate iron stores, a condition known as functional iron deficiency. Understanding the foundational mechanisms and clinical implications of renal anemia is essential for timely diagnosis and effective management. Recognizing early signs and symptoms, such as pallor, fatigue, and shortness of breath, can prompt further investigation and intervention. With the right approach, healthcare providers can slow the progression of anemia, enhance patient well-being, and improve long-term outcomes in those living with chronic kidney disease. Definition and classification. Renal anemia is defined as a form of anemia that arises as a direct consequence of chronic kidney disease, CKD, typically due to inadequate production of erythropoietin, EPO, by the kidneys. Erythropoietin is a glycoprotein hormone that plays a vital role in stimulating the bone marrow to produce red blood cells. In healthy individuals, the kidneys respond to low oxygen levels in the blood by increasing EPO production. However, in CKD, damaged renal tissue loses its ability to produce sufficient EPO, leading to a decline in red blood cell production and the onset of anemia. Clinically, renal anemia is characterized by a reduction in hemoglobin concentration below normal reference values. According to the World Health Organization, WHO, anemia is defined as hemoglobin levels less than 13 grams per deciliter in men and less than 12 grams per deciliter in women. In patients with CKD, the prevalence and severity of anemia typically increase as glomerular filtration rate, GFR, declines. This relationship makes renal anemia a progressive condition, closely linked with the stages of kidney disease. The classification of renal anemia can be approached from several perspectives. One common way is to categorize it by severity, mild, moderate, or severe, based on hemoglobin levels. Another approach involves distinguishing between absolute and functional iron deficiency anemia. Absolute iron deficiency occurs when iron stores in the body are depleted, often due to poor dietary intake, gastrointestinal losses, or blood loss during dialysis. Functional iron deficiency, on the other hand, arises when iron stores are sufficient but cannot be properly utilized due to chronic inflammation or the effects of certain therapies such as erythropoiesis-stimulating agents, ESAs. Renal anemia is also classified based on its morphological characteristics. It is typically normocytic, normal-sized red blood cells, and normochromic, normal hemoglobin content, although variations can occur depending on coexisting conditions such as vitamin B12 or folate deficiency, which can lead to macrocytic anemia. Furthermore, it may overlap with anemia of chronic disease, a condition characterized by disrupted iron homeostasis, reduced red blood cell lifespan, and impaired erythropoiesis due to ongoing inflammation. Understanding the definition and various classifications of renal anemia is crucial for guiding appropriate diagnostic and therapeutic strategies. By accurately identifying the type and severity of anemia, clinicians can tailor treatments that address the underlying causes and improve both hematologic parameters and patient outcomes in those with chronic kidney disease. Epidemiology and prevalence. Renal anemia is a widespread complication of chronic kidney disease, CKD, affecting a significant proportion of patients at various stages of kidney dysfunction. Its prevalence increases as kidney function deteriorates, making it a major clinical concern in both non-dialysis and dialysis-dependent CKD populations. Understanding the epidemiology and prevalence of renal anemia is essential for public health planning, resource allocation, and the development of effective clinical management strategies. Globally, chronic kidney disease affects approximately 10% to 15% of the adult population, and among these individuals, anemia is a frequent and often underdiagnosed comorbidity. Studies have shown that the prevalence of anemia in CKD stage 3, moderate disease, is around 30% to 40%, rising sharply in stages 4 and 5. By the time patients reach end-stage renal disease, ESRD, and require dialysis, anemia is present in over 90% of cases. This strong correlation between declining glomerular filtration rate, GFR, and hemoglobin levels underscores the progressive nature of renal anemia and the importance of early intervention. The burden of renal anemia is not evenly distributed across all populations. Elderly patients, individuals with diabetes, and those with cardiovascular disease are particularly susceptible. Furthermore, racial and ethnic disparities have been observed, with higher prevalence rates reported among African American and Hispanic populations. These differences may reflect a combination of genetic factors, comorbid conditions, healthcare access, and socioeconomic determinants. In the dialysis population, anemia remains highly prevalent despite advances in treatment options, including the widespread use of erythropoiesis-stimulating agents, ESAs, and intravenous iron therapy. Hemoglobin targets vary slightly among clinical guidelines, but maintaining optimal levels remains a challenge due to fluctuating iron status, chronic inflammation, and patient-specific factors. Moreover, undertreatment or delayed diagnosis of anemia in pre-dialysis CKD patients is common, contributing to poorer outcomes and increased healthcare utilization. Renal anemia significantly impacts patient morbidity and mortality. It is associated with decreased quality of life, increased rates of hospitalization, progression of left ventricular hypertrophy, and higher cardiovascular risk. In addition to its clinical implications, renal anemia places a substantial economic burden on healthcare systems due to increased treatment costs, frequent monitoring, and associated complications. Understanding the epidemiological trends of renal anemia highlights the need for systematic screening and early intervention in patients with CKD. By recognizing at-risk populations and implementing proactive management strategies, healthcare providers can mitigate the complications of anemia and improve outcomes for patients living with chronic kidney disease. Pathophysiology Overview. The pathophysiology of renal anemia is multifactorial and closely linked to the progressive decline in kidney function seen in chronic kidney disease, CKD. The most central and well-recognized mechanism involves the reduced production of erythropoietin, EPO, a glycoprotein hormone synthesized predominantly by peritubular fibroblasts in the renal cortex. In response to hypoxia, healthy kidneys increase EPO secretion, which stimulates erythropoiesis in the bone marrow. However, in CKD, as the functional renal mass decreases, the capacity to produce EPO diminishes significantly, resulting in decreased stimulation of red blood cell production and subsequent anemia. Beyond EPO deficiency, several additional mechanisms contribute to the development and persistence of anemia in CKD patients. One of the most common is iron deficiency, which can be either absolute or functional. Absolute iron deficiency refers to depleted iron stores due to factors such as poor dietary intake, gastrointestinal blood loss, or frequent phlebotomy. Functional iron deficiency, on the other hand, occurs when iron stores are adequate but not bioavailable for erythropoiesis, often due to chronic inflammation interfering with iron transport and utilization. Inflammation plays a critical role in the pathogenesis of renal anemia. Inflammatory cytokines, such as interleukin-6, Illinois-6, can induce the production of hepcidin, a liver-derived hormone that regulates iron homeostasis. Elevated hepcidin levels block the release of iron from macrophages and inhibit intestinal iron absorption, leading to decreased iron availability despite sufficient iron stores. This inflammation-driven iron dysregulation is a hallmark of anemia of chronic disease, which often overlaps with renal anemia in CKD patients. Another contributing factor is the shortened lifespan of red blood cells in CKD. Normally, red blood cells have a lifespan of about 120 days, but in CKD, uremic toxins and oxidative stress can lead to premature destruction of these cells. Additionally, bone marrow suppression may occur due to the toxic effects of uremia or the presence of secondary hyperparathyroidism, further impairing erythropoiesis. Nutritional deficiencies, such as low levels of vitamin B12 and folate, can also contribute to anemia in some CKD patients, although these are less common causes. Moreover, frequent blood loss during hemodialysis sessions or from gastrointestinal sources can exacerbate anemia and increase the need for red blood cell replacement. In summary, the pathophysiology of renal anemia is complex and involves a combination of inadequate erythropoietin production, iron dysregulation, chronic inflammation, red blood cell destruction, and marrow suppression. A thorough understanding of these mechanisms is essential for effective diagnosis and individualized treatment in patients with CKD. Chapter 2. The role of the kidneys in erythropoiesis. The kidneys play a vital role in the regulation of erythropoiesis, the process through which new red blood cells, erythrocytes, are produced. This role is primarily mediated through the production of erythropoietin, EPO, a hormone that stimulates the bone marrow to increase red blood cell formation in response to hypoxia or low oxygen levels in the blood. Under normal physiological conditions, the kidneys continuously monitor the oxygen content of the blood and adjust EPO production accordingly to maintain oxygen homeostasis. Erythropoietin is synthesized predominantly by specialized interstitial fibroblast-like cells located in the peritubular capillary bed of the renal cortex. When oxygen delivery to the kidneys is reduced, as in anemia, high altitudes, or chronic lung disease, these cells respond by significantly upregulating EPO production. EPO then travels through the bloodstream to the bone marrow, where it binds to erythroid progenitor cells, stimulating their survival, proliferation, and differentiation into mature red blood cells. As red blood cell numbers increase and oxygen delivery improves, EPO levels decline through a negative feedback mechanism. In patients with chronic kidney disease, CKD, the kidney's ability to produce EPO becomes progressively impaired. This is due not only to the loss of functional nephrons, but also to damage and fibrosis affecting the EPO-producing cells. As kidney function declines, EPO production drops below the threshold needed to maintain adequate red blood cell counts, leading to anemia. Importantly, even in the presence of hypoxia, diseased kidneys fail to mount an appropriate EPO response, making this a primary driver of anemia in CKD. The disruption of erythropoiesis in CKD has broad systemic consequences. Reduced red blood cell production results in decreased oxygen delivery to tissues, triggering fatigue, dyspnea, cognitive impairment, and reduced exercise capacity. In addition, chronic anemia contributes to cardiovascular strain, including left ventricular hypertrophy and heart failure, further complicating CKD management. While the kidneys are the principal site of EPO production in adults, it is worth noting that during fetal development, the liver serves this function. As development progresses, the responsibility shifts almost entirely to the kidneys, highlighting their central role in long-term erythropoiesis. Advances in the understanding of this renal endocrine axis have led to the development of erythropoiesis-stimulating agents, ESAs, and newer therapies targeting hypoxia-inducible factors, aiming to restore effective red blood cell production in patients with renal anemia. Overall, the kidney's function in erythropoiesis underscores the deep interconnectedness between renal health and hematologic balance, and any disruption to this system has far-reaching clinical implications. Erythropoietin production. Erythropoietin, EPO, is a glycoprotein hormone that plays a crucial role in the regulation of red blood cell production. It is primarily produced by the kidneys in response to hypoxia, or low oxygen levels in the blood. The production of erythropoietin is a finely tuned physiological process that ensures adequate oxygen delivery to tissues by maintaining appropriate levels of circulating red blood cells. This hormone acts directly on the bone marrow to stimulate the proliferation and differentiation of erythroid progenitor cells, ultimately increasing red blood cell output. In healthy adults, about 90% of erythropoietin is produced in the kidneys, specifically by peritubular interstitial cells in the renal cortex. These cells detect decreases in tissue oxygenation through oxygen-sensing mechanisms that involve hypoxia-inducible factors, HIFs. When oxygen levels fall, HIFs accumulate in the cell nucleus and activate the transcription of the EPO gene, leading to increased erythropoietin synthesis and secretion into the bloodstream. Once oxygen levels normalize, HIFs are degraded, and EPO production diminishes, completing the feedback loop. The liver also contributes to erythropoietin production, particularly during fetal development. In the fetus, the liver is the primary site of EPO synthesis, but after birth, this role transitions to the kidneys. In adults with significant renal impairment, the liver may provide a minimal compensatory increase in EPO production, but this is usually insufficient to prevent anemia in the setting of chronic kidney disease, CKD. The relationship between erythropoietin and anemia becomes particularly significant in CKD. As kidney function deteriorates, the number of functional EPO-producing cells declines, and their ability to respond to hypoxia is impaired. Even in the face of severe anemia, patients with CKD may have inappropriately low levels of erythropoietin, highlighting the hormone's central role in the development of renal anemia. This deficiency is a key target for treatment with erythropoiesis-stimulating agents, ESAs, which are synthetic versions of EPO designed to restore red blood cell production. Recent research has expanded our understanding of erythropoietin regulation through the HIF pathway. Hypoxia-inducible factor prolyl hydroxylase inhibitors, HIF-5s, are a new class of drugs that stabilize HIFs, thereby enhancing endogenous EPO production, even in patients with damaged kidneys. These therapies represent a promising advancement in the management of renal anemia, offering a more physiologic approach to stimulating erythropoiesis. Erythropoietin production is a fundamental process in human physiology, and its disruption in CKD underscores the importance of kidney health in maintaining hematologic balance and systemic oxygen delivery. Kidney function and red blood cell regulation. The kidneys are not only essential for filtering waste products from the blood and regulating fluid balance, but they also play a pivotal role in the regulation of red blood cell production. This connection is largely mediated through the synthesis of erythropoietin, EPO, a hormone responsible for stimulating the production of red blood cells in the bone marrow. The intricate link between kidney function and erythropoiesis makes the kidneys central to the maintenance of adequate hemoglobin levels and systemic oxygen delivery. Under normal physiological conditions, the kidneys continuously monitor the oxygen saturation of blood as it passes through the renal arteries. Specialized peritubular interstitial cells in the renal cortex act as oxygen sensors. When they detect hypoxia or a reduced oxygen supply, they respond by producing and releasing erythropoietin into the bloodstream. This hormone then travels to the bone marrow, where it binds to EPO receptors on erythroid progenitor cells, promoting their survival, proliferation, and maturation into functional red blood cells. As oxygen levels normalize due to increased red blood cell mass, EPO production is downregulated through negative feedback mechanisms involving oxygen-sensitive transcription factors. In chronic kidney disease, CKD, this regulatory system becomes progressively impaired. As nephron loss and renal fibrosis advance, the number and functionality of EPO-producing cells decline. The kidney's capacity to detect hypoxia and respond appropriately diminishes, resulting in reduced EPO production even in the presence of anemia. This contributes directly to the development of renal anemia, a common and often debilitating complication in CKD patients. The consequences of this impaired regulation extend beyond hematologic parameters. Reduced red blood cell counts lead to inadequate oxygen delivery to vital organs and tissues, causing fatigue, cognitive dysfunction, and decreased exercise tolerance. The chronic state of anemia also imposes additional workload on the heart, often leading to left ventricular hypertrophy and increased risk of cardiovascular events. In addition to hormonal control via EPO, kidney function also influences red blood cell regulation through indirect mechanisms. These include the maintenance of iron balance, modulation of inflammatory responses, and interaction with other endocrine systems, such as the parathyroid and renin-angiotensin-aldosterone systems. Each of these factors can further complicate the erythropoietic process in patients with renal dysfunction. Ultimately, the kidneys serve as both a sensor and regulator in the delicate balance of red blood cell production. Any disruption in renal function can lead to a cascade of hematological imbalances, emphasizing the need for early recognition and comprehensive management of anemia in patients with kidney disease. Impact of chronic kidney disease, CKD. Chronic kidney disease, CKD, significantly impacts nearly every aspect of human physiology, with one of its most profound effects being on the hematologic system. Among the most common and debilitating complications of CKD is renal anemia, a condition marked by reduced red blood cell production, primarily due to the kidney's impaired ability to produce erythropoietin, EPO. As CKD progresses, the cumulative effects on erythropoiesis, iron metabolism, and systemic inflammation contribute to the onset and worsening of anemia, which in turn accelerates disease progression and worsens patient outcomes. The progression of CKD involves the gradual and irreversible loss of nephrons, the functional units of the kidney. This leads to a decline in the kidney's ability to perform essential functions, including the synthesis of erythropoietin. In healthy individuals, EPO is produced in response to low oxygen levels, and stimulates the bone marrow to produce red blood cells. In CKD, damaged kidney tissue cannot generate enough EPO to meet the body's needs, even in the presence of significant anemia. This EPO deficiency is the central mechanism behind renal anemia. Beyond EPO production, CKD affects red blood cell health and longevity. Uremic toxins that accumulate due to inadequate filtration contribute to red blood cell membrane instability, resulting in shortened red blood cell lifespan. Additionally, the bone marrow environment in CKD patients can become less responsive to erythropoietin due to systemic inflammation and the presence of other metabolic disturbances. These changes impair the efficiency of erythropoiesis even when EPO therapy is administered. Iron metabolism is also disrupted in CKD. Many patients suffer from functional or absolute iron deficiency, which further limits red blood cell production. Chronic inflammation common in CKD elevates levels of hepcidin, a regulatory hormone that inhibits both dietary iron absorption and the release of stored iron from macrophages. This creates a paradox in which iron is present in the body, but remains inaccessible for effective erythropoiesis. The impact of CKD-induced anemia is substantial. Patients frequently experience fatigue, decreased exercise tolerance, cognitive impairment, and a diminished quality of life. Anemia also places an increased burden on the cardiovascular system, leading to left ventricular hypertrophy, heart failure, and elevated mortality risk. These outcomes create a cycle where anemia exacerbates CKD progression and vice versa. In conclusion, CKD exerts a multifaceted and progressive influence on red blood cell production and survival, leading to a cascade of complications. Understanding the depth of this impact is essential for timely diagnosis, effective treatment, and improving outcomes for individuals living with chronic kidney disease. Chapter 3: Clinical Manifestations of Renal Anemia. Renal anemia presents with a range of clinical manifestations that reflect the systemic effects of reduced oxygen carrying capacity in the blood. These symptoms often develop insidiously and may be initially attributed to other aspects of chronic kidney disease, CKD. However, as anemia progresses, the signs become more pronounced and have a significant impact on the patient's functional status, quality of life, and overall prognosis. Understanding these manifestations is crucial for timely recognition and appropriate intervention. One of the earliest and most common symptoms of renal anemia is fatigue. Patients frequently report a persistent sense of tiredness or lack of energy that is not relieved by rest. This fatigue results from insufficient oxygen delivery to tissues and organs, impairing cellular metabolism and reducing overall physical capacity. As the anemia worsens, patients may also experience shortness of breath, particularly with exertion, due to the body's compensatory efforts to increase oxygen uptake and delivery. Cognitive disturbances, including difficulty concentrating, memory problems, and reduced mental alertness, are also reported in individuals with renal anemia. These changes are likely the result of chronic cerebral hypoxia and can severely impact daily activities and social functioning. In children, anemia may affect growth and cognitive development, underscoring the importance of early detection and treatment. Another hallmark of renal anemia is pallor, which may be observed in the skin, mucous membranes, and nail beds. This physical sign reflects the reduced hemoglobin concentration and decreased perfusion. In more severe cases, patients may also develop dizziness, lightheadedness, or even syncope, especially upon standing, due to reduced oxygenation of the brain and impaired autonomic regulation. The cardiovascular system is particularly vulnerable to the effects of chronic anemia. In an attempt to compensate for low hemoglobin levels, the heart increases its output, which can eventually lead to left ventricular hypertrophy, congestive heart failure, and arrhythmias. These complications significantly increase the risk of morbidity and mortality in patients with CKD. Additionally, anemia can exacerbate existing cardiovascular conditions, creating a cycle of worsening cardiac and renal function. Other less specific symptoms include cold intolerance, headaches, and a general sense of weakness. These manifestations may overlap with other symptoms of CKD, making it essential for healthcare providers to consider anemia in the differential diagnosis and monitor hemoglobin levels regularly. In summary, the clinical manifestations of renal anemia are diverse and affect multiple organ systems. They reflect the body's struggle to function under conditions of chronic hypoxia and are a key contributor to the overall disease burden in CKD. Prompt identification and management of anemia can lead to substantial improvements in patient outcomes and quality of life. Common signs and symptoms. Renal anemia, as a complication of chronic kidney disease, CKD, manifests with a variety of signs and symptoms that can significantly affect a patient's daily life and overall well-being. These clinical features arise primarily from the body's inability to deliver sufficient oxygen to tissues and organs, due to the reduced number of red blood cells. Although the symptoms may be subtle in the early stages, they tend to worsen as anemia becomes more pronounced, making early recognition crucial for improving patient outcomes. Fatigue is one of the most common and debilitating symptoms of renal anemia. As the oxygen-carrying capacity of the blood decreases, patients experience a constant sense of tiredness that does not improve with rest. This persistent fatigue results from insufficient oxygen supply to tissues, leading to impaired energy production and a decreased ability to perform routine activities. In some cases, the fatigue may be severe enough to affect the ability to work or engage in social activities, reducing the overall quality of life. Shortness of breath is another frequent symptom, particularly with exertion. The body attempts to compensate for the lack of oxygen-carrying red blood cells by increasing the respiratory rate, which can lead to a sensation of breathlessness, even with minimal physical activity. This symptom often worsens as anemia progresses, making it difficult for patients to engage in exercise or daily physical tasks without becoming winded. Cognitive symptoms are also common in individuals with renal anemia. Patients may experience difficulty concentrating, memory problems, and reduced mental clarity. This can be attributed to reduced oxygen supply to the brain, which impacts cognitive function. In addition to impairing decision-making and attention, cognitive dysfunction can also affect mood, leading to irritability or depression. Pallor or pale skin is another visible sign of renal anemia. The reduced number of red blood cells means there is less hemoglobin available to give the skin its usual rosy hue. Pallor may be most noticeable in areas such as the face, nails, and inner eyelids. In severe cases, the skin may appear almost grayish or ashen, indicating more significant anemia. Dizziness or lightheadedness, especially when standing up quickly, is also a frequent complaint in patients with renal anemia. This symptom occurs as a result of decreased blood volume and inadequate oxygenation of the brain. In extreme cases, anemia can lead to syncope, fainting, particularly in those with additional cardiovascular complications. Other common symptoms include headaches, cold intolerance, and a general feeling of weakness. These nonspecific signs can be mistaken for other conditions, but are important indicators of the underlying anemia. Left untreated, these symptoms can worsen, leading to more severe complications, including cardiovascular events and further renal decline. In summary, renal anemia presents with a wide range of symptoms that can significantly affect a patient's physical and mental well-being. Early identification and management of these signs are essential for improving the quality of life and preventing the progression of associated complications in patients with chronic kidney disease. Effects on cardiovascular health. Renal anemia, a common complication of chronic kidney disease, CKD, has significant effects on cardiovascular health, creating a complex and often detrimental interplay between the heart and kidneys. Anemia leads to a reduced number of red blood cells, which in turn decreases the oxygen-carrying capacity of the blood. As a result, the body attempts to compensate for the lack of oxygen by increasing cardiac output, but this compensatory mechanism can lead to a range of cardiovascular problems, exacerbating both renal and heart disease. One of the most notable cardiovascular effects of renal anemia is the development of left ventricular hypertrophy, LVH. LVH occurs when the heart's left ventricle becomes enlarged and thickened in response to increased workload. The body compensates for the diminished oxygen supply by driving the heart to pump more vigorously, but this increased demand can strain the heart muscle over time. LVH is not only a risk factor for heart failure, but also worsens the prognosis in patients with CKD, as it increases the likelihood of arrhythmias, myocardial infarction, and other cardiovascular events. Anemia also contributes to the development of congestive heart failure, CHF, a condition where the heart is unable to pump blood efficiently to meet the body's needs. In the setting of anemia, the heart works harder to compensate for the lower oxygen levels in the blood, leading to further stress on the cardiovascular system. Over time, this can lead to fluid retention, elevated blood pressure, and reduced ejection fraction, all hallmarks of heart failure. Patients with both CKD and anemia are at significantly higher risk for developing CHF compared to those without anemia, further complicating management. In addition to LVH and heart failure, anemia in CKD increases the risk of ischemic heart disease. As the heart works harder to deliver oxygen to tissues, there is an increased demand for coronary blood flow. However, in individuals with CKD, the coronary arteries may already be compromised due to atherosclerosis, leaving the heart vulnerable to ischemia. This reduced oxygen supply to the heart muscle can lead to angina, heart attacks, and other serious cardiovascular issues. Another cardiovascular concern related to renal anemia is the increased risk of arrhythmias. The altered hemodynamics associated with anemia, coupled with electrolyte imbalances that often occur in CKD, create an environment conducive to the development of irregular heart rhythms. Arrhythmias, especially atrial fibrillation, are common in CKD patients with anemia, and they further elevate the risk of stroke and other cardiovascular events. In conclusion, renal anemia significantly impacts cardiovascular health, creating a vicious cycle that exacerbates both kidney and heart function. Effective management of anemia in CKD patients is critical not only to alleviate symptoms such as fatigue and shortness of breath, but also to reduce the risk of cardiovascular complications like left ventricular hypertrophy, heart failure, ischemic heart disease, and arrhythmias. Addressing anemia early and comprehensively can lead to improved outcomes and a better quality of life for patients suffering from CKD. Quality of life considerations. The impact of renal anemia on quality of life, QOL, is profound and multifaceted, affecting nearly every aspect of a patient's physical, emotional, and social well-being. Renal anemia, often a complication of chronic kidney disease, CKD, is associated with a variety of symptoms such as fatigue, weakness, shortness of breath, and cognitive dysfunction, all of which can significantly reduce a patient's ability to carry out daily activities. These symptoms, while directly related to anemia, also exacerbate the underlying condition of CKD, leading to a diminished overall quality of life. Fatigue is one of the most debilitating symptoms of renal anemia, often being the first and most noticeable complaint from patients. This chronic fatigue is not alleviated by rest and can make simple tasks such as walking, cooking, or engaging in social activities seem overwhelming. As patients struggle with day-to-day functioning, the physical limitations imposed by anemia contribute to feelings of frustration, isolation, and depression. In fact, the persistent exhaustion associated with renal anemia can lead to a significant reduction in the patient's ability to work or participate in their usual routines, thereby severely impacting their overall quality of life. The mental and emotional toll of renal anemia is also considerable. Cognitive symptoms, including difficulty concentrating, memory issues, and reduced mental clarity, are common in patients with CKD-related anemia. These cognitive impairments can affect job performance, personal relationships, and the ability to manage daily tasks, further contributing to emotional distress and decreased QOL. The constant battle with low energy and physical limitations can also lead to feelings of helplessness and a decline in mental health, including depression and anxiety, which are common comorbidities in individuals with CKD. Furthermore, the physical symptoms of renal anemia, such as pallor, shortness of breath, and dizziness, can lead to embarrassment and social withdrawal. People with noticeable symptoms may feel self-conscious or avoid public spaces, leading to a diminished social life. This isolation, in turn, can worsen the emotional and psychological burden of living with a chronic illness. The effects of anemia on cardiovascular health also play a role in reducing QOL. The increased strain on the heart, particularly in individuals with pre-existing heart disease, may exacerbate symptoms like chest pain and shortness of breath, making even simple physical activities increasingly difficult. This can create a cycle of physical limitations and reduced quality of life, as patients find themselves unable to engage in activities that they once enjoyed or even take care of basic needs. In conclusion, renal anemia significantly diminishes the quality of life for individuals with CKD, not only through physical symptoms, but also through its impact on emotional, cognitive, and social well-being. Addressing anemia in CKD patients is essential to improving overall quality of life. Effective treatment strategies, such as erythropoiesis-stimulating agents, ESAs, iron supplementation, and managing underlying kidney disease, can help alleviate symptoms, restore energy levels, and improve both physical function and emotional well-being, ultimately enhancing the patient's quality of life. Chapter 4: Diagnostic Evaluation. The diagnostic evaluation of renal anemia is essential for identifying the underlying causes of anemia and determining the most effective treatment strategies. Since renal anemia is primarily associated with chronic kidney disease, CKD, it is crucial to distinguish between anemia due to kidney dysfunction and other potential causes, such as iron deficiency, chronic inflammation, or bone marrow suppression. A comprehensive diagnostic approach involves clinical assessment, laboratory tests, and imaging studies to evaluate both renal function and hematologic status. The first step in the diagnostic evaluation is a thorough clinical assessment, which includes a detailed history and physical examination. The physician will assess symptoms such as fatigue, pallor, shortness of breath, and dizziness, all of which are commonly associated with anemia. Additionally, a history of kidney disease, diabetes, hypertension, or other conditions that predispose to CKD will help guide the clinician toward the diagnosis of renal anemia. The physical exam may reveal signs such as pallor, tachycardia, or an elevated blood pressure, which are often indicative of anemia and CKD. Laboratory tests play a central role in diagnosing renal anemia. A complete blood count, CBC, is the most basic test used to assess anemia, revealing reduced hemoglobin, HB, and hematocrit, HCT levels, as well as a low red blood cell count. The mean corpuscular volume, MCV, and red cell distribution width, RDW, may also be evaluated to help determine the type of anemia. In renal anemia, the MCV is typically normal or slightly reduced, as the anemia is usually normocytic. In contrast, other types of anemia, such as iron deficiency anemia, may present with microcytic cells. The measurement of erythropoietin levels is also critical in the diagnostic process. In patients with CKD, erythropoietin levels are often inappropriately low for the degree of anemia. This is because the kidney's ability to produce erythropoietin diminishes as kidney function declines. In contrast, in cases of anemia caused by other factors, such as iron deficiency, erythropoietin levels may remain relatively normal or elevated. Iron studies are another important aspect of the diagnostic workup. Since iron deficiency can coexist with CKD and exacerbate anemia, iron studies including serum iron, ferritin, transferrin saturation, and total iron binding capacity (TIBC) should be measured. In patients with CKD, functional iron deficiency is common, where there is adequate iron stores, but the body cannot use it effectively for red blood cell production due to elevated levels of hepcidin. Additional tests may include assessing kidney function through serum creatinine and estimated glomerular filtration rate, eGFR, to gauge the extent of renal impairment. A low eGFR confirms CKD, and in combination with the anemia, supports the diagnosis of renal anemia. In conclusion, diagnosing renal anemia requires a comprehensive evaluation that includes a clinical history, physical examination, laboratory tests, and sometimes imaging studies. By accurately identifying the cause and severity of anemia, healthcare providers can develop targeted treatment plans to address both the anemia and the underlying kidney dysfunction, improving patient outcomes and quality of life. Laboratory investigations. Laboratory investigations play a critical role in the diagnosis and management of renal anemia, allowing healthcare providers to assess the underlying causes of anemia and monitor the effectiveness of treatment. These investigations help distinguish renal anemia from other forms of anemia and identify any contributing factors, such as iron deficiency, inflammation, or erythropoietin deficiency. A comprehensive approach to laboratory testing includes blood tests, iron studies, and markers of kidney function, each providing valuable insights into the patient's condition. A complete blood count, CBC, is often the first laboratory test performed in patients suspected of having anemia. It measures key parameters such as hemoglobin, HB, hematocrit, HCT, red blood cell, RBC count, and mean corpuscular volume, MCV. In renal anemia, the HB and HCT levels are typically low, reflecting the reduced oxygen-carrying capacity of the blood. The MCV is usually within normal limits or slightly reduced, indicating normocytic anemia, which is characteristic of renal anemia caused by impaired erythropoietin production. The red blood cell count is also reduced, but it may not be as low as expected in other types of anemia, such as iron deficiency anemia. Erythropoietin, EPO levels, are another important laboratory test in the evaluation of renal anemia. EPO is a hormone primarily produced by the kidneys in response to low oxygen levels, stimulating the production of red blood cells in the bone marrow. In CKD, the kidney's ability to produce EPO diminishes as renal function declines. Therefore, in patients with renal anemia, EPO levels are typically inappropriately low for the degree of anemia, making it an essential marker in the diagnosis. Elevated EPO levels in the context of anemia may suggest other causes of anemia, such as blood loss or hemolysis. Iron studies are essential in assessing iron status and determining whether iron deficiency is contributing to the anemia. These studies typically include measurements of serum iron, ferritin, transferrin saturation, TSAT, and total iron binding capacity, TIBC. Ferritin is a key marker of iron stores in the body, and in patients with CKD, ferritin levels may be elevated due to inflammation, even when iron stores are inadequate for red blood cell production. Transferrin saturation, calculated as serum iron divided by TIBC, provides insight into the availability of iron for erythropoiesis. Low transferrin saturation and high ferritin levels in the context of CKD suggest functional iron deficiency, where iron is present in the body but is not effectively utilized due to elevated hepcidin levels. In addition to these core tests, kidney function markers such as serum creatinine and estimated glomerular filtration rate, eGFR, are essential for assessing the severity of renal impairment and confirming the diagnosis of CKD. A low eGFR and elevated serum creatinine levels are indicative of reduced kidney function, which is a critical factor in the development of renal anemia due to decreased erythropoietin production. In summary, laboratory investigations are central to the diagnosis and management of renal anemia. By evaluating parameters such as the CBC, erythropoietin levels, iron studies, and kidney function markers, clinicians can accurately diagnose renal anemia, determine its underlying causes, and tailor treatment strategies to improve patient outcomes. Regular monitoring through these laboratory tests also helps assess the effectiveness of therapeutic interventions and guide ongoing management. Differentiating from other anemias. Differentiating renal anemia from other types of anemia is a crucial step in ensuring an accurate diagnosis and effective treatment. Renal anemia, which is primarily caused by chronic kidney disease, CKD, differs from other common forms of anemia, such as iron deficiency anemia, anemia of chronic disease, ACD, and hemolytic anemia in both its pathophysiology and laboratory findings. Properly distinguishing between these anemias requires a comprehensive understanding of their unique characteristics and diagnostic markers. One of the most common types of anemia that must be differentiated from renal anemia is iron deficiency anemia, IDA. Both conditions can present with similar symptoms, such as fatigue and pallor, but the underlying causes differ. In IDA, the primary issue is insufficient iron for hemoglobin production, often due to inadequate dietary intake, malabsorption, or blood loss. Laboratory tests in IDA typically show low serum ferritin levels, indicating depleted iron stores, low transferrin saturation, and an elevated total iron binding capacity, TIBC. In contrast, renal anemia is characterized by an inappropriately low erythropoietin, EPO level, relative to the degree of anemia. Additionally, iron studies in renal anemia may show normal or elevated ferritin levels, reflecting the presence of iron stores, but with impaired iron utilization due to high hepcidin levels. The presence of CKD, indicated by a low glomerular filtration rate, GFR, is also a distinguishing feature of renal anemia. Anemia of chronic disease, ACD, or anemia of inflammation, is another condition that can overlap with renal anemia. ACD is commonly seen in conditions such as infection, cancer, and autoimmune diseases, as well as CKD. However, while both renal anemia and ACD are associated with chronic illness, the mechanism of anemia differs. In ACD, inflammation leads to increased levels of hepcidin, which impairs iron absorption and release from stores, preventing its effective use for red blood cell production. Like renal anemia, ACD often presents with normal or elevated ferritin levels, but the key difference is that patients with ACD typically do not have significant renal impairment or low erythropoietin levels. Renal anemia, on the other hand, is specifically linked to decreased EPO production due to kidney dysfunction, a factor that is not present in ACD. Hemolytic anemia, caused by the premature destruction of red blood cells, presents with symptoms such as jaundice and dark urine, which are not typically seen in renal anemia. Laboratory findings in hemolytic anemia include elevated reticulocyte counts and increased levels of lactate dehydrogenase, LDH, and indirect bilirubin, which are markers of red blood cell breakdown. In contrast, renal anemia is characterized by a reduced reticulocyte count, reflecting the impaired production of new red blood cells due to low erythropoietin levels. In summary, differentiating renal anemia from other forms of anemia is essential for accurate diagnosis and appropriate management. By evaluating clinical features, laboratory tests, and underlying conditions such as CKD, clinicians can distinguish renal anemia from iron deficiency anemia, anemia of chronic disease, and hemolytic anemia. Understanding these differences allows for targeted treatment strategies, including erythropoiesis-stimulating agents, iron supplementation, or addressing the underlying cause of anemia. Biomarkers and emerging tools. The diagnosis and management of renal anemia have evolved with the introduction of novel biomarkers and emerging diagnostic tools. Biomarkers play a critical role in distinguishing renal anemia from other types of anemia, assessing the severity of the condition, and guiding treatment decisions. These biomarkers are particularly valuable in the context of chronic kidney disease, CKD, where the accurate assessment of anemia is essential for effective management. As research in the field continues to progress, several new biomarkers and diagnostic technologies are being explored to enhance the precision and efficiency of renal anemia diagnosis. One of the most significant biomarkers in the context of renal anemia is erythropoietin, EPO, a hormone produced by the kidneys that stimulates red blood cell production. In renal anemia, EPO levels are typically inappropriately low for the degree of anemia due to impaired kidney function. Measurement of EPO levels is crucial for confirming a diagnosis of renal anemia, particularly when distinguishing it from other anemias, such as iron deficiency anemia. However, EPO testing alone is not always sufficient, as its levels can also be influenced by other factors, including inflammation and infection. Therefore, EPO measurement is often used in conjunction with other diagnostic tests to provide a more comprehensive picture of the patient's condition. Ferritin, a protein that stores iron in the body, is another important biomarker in the assessment of renal anemia. In patients with CKD, ferritin levels may be elevated due to inflammation, which is commonly seen in kidney disease. This can make it challenging to assess the true iron status of a patient. To address this challenge, newer biomarkers such as soluble transferrin receptor, STFR, and hepcidin have been explored. The soluble transferrin receptor is a marker of iron demand, and its levels are elevated in cases of iron deficiency, making it a useful tool in differentiating between renal anemia and iron deficiency anemia. Hepcidin, a regulator of iron homeostasis, is also an emerging biomarker in renal anemia. Elevated hepcidin levels are often associated with functional iron deficiency, a condition in which iron is present in the body, but cannot be effectively utilized for erythropoiesis due to high hepcidin levels. Measurement of both hepcidin and STFR can help clinicians identify patients who may benefit from iron supplementation or erythropoiesis-stimulating agents. In addition to these biomarkers, novel diagnostic tools and technologies are being developed to improve the assessment of renal anemia. One such tool is the measurement of reticulocyte hemoglobin content, CHR, which provides insight into the availability of iron for red blood cell production. This test is useful in identifying functional iron deficiency, even when traditional iron markers, such as serum ferritin, are elevated due to inflammation. Another emerging technology is the use of high-sensitivity troponin assays to detect myocardial injury, which may be more common in patients with both renal anemia and CKD. These assays can help identify patients at risk for cardiovascular events, which are a significant concern in renal anemia. In conclusion, the use of biomarkers and emerging diagnostic tools has significantly improved the ability to diagnose and manage renal anemia. By providing more accurate assessments of iron status, erythropoiesis, and kidney function, these biomarkers and technologies help guide treatment decisions and improve patient outcomes. As research continues, the development of new biomarkers and diagnostic tools holds the potential to further refine the diagnosis and management of renal anemia, leading to more personalized and effective treatment strategies. Chapter 5: Conventional Treatment Approaches. The management of renal anemia has traditionally involved a combination of pharmacologic interventions, dietary management, and addressing underlying causes, particularly chronic kidney disease, CKD. Conventional treatment approaches have focused on improving hemoglobin levels, reducing symptoms, and preventing complications such as cardiovascular disease and reduced exercise capacity. These approaches primarily include the use of erythropoiesis-stimulating agents, ESAs, iron supplementation, and in some cases blood transfusions, with the goal of restoring red blood cell production and improving overall patient outcomes. Erythropoiesis-stimulating agents, ESAs, have long been the cornerstone of treatment for renal anemia, particularly in patients with CKD. These agents, such as apoetin alpha and darbepoetin alpha, mimic the action of erythropoietin, a hormone naturally produced by the kidneys that stimulates the production of red blood cells in the bone marrow. In CKD, the kidney's ability to produce erythropoietin diminishes, leading to anemia. ESAs are administered via injection and have been shown to significantly increase hemoglobin levels and reduce the need for blood transfusions in patients with renal anemia. However, the use of ESAs requires careful monitoring, as overcorrection of anemia can lead to complications, including hypertension, thromboembolic events, and increased mortality. Adjusting the dosage of ESAs to achieve and maintain appropriate hemoglobin levels is essential to minimizing these risks. Iron supplementation is another fundamental component of conventional treatment for renal anemia. Iron is crucial for the production of hemoglobin, and many patients with CKD and renal anemia experience iron deficiency, either due to poor dietary intake, reduced absorption, or the chronic inflammatory state associated with kidney disease. Oral iron supplements are commonly prescribed to address iron deficiency. However, they are often poorly absorbed, particularly in patients with advanced CKD. Intravenous iron, administered through infusion, has become the preferred method for iron supplementation in these patients, as it provides more efficient replenishment of iron stores. Intravenous iron has been shown to improve the efficacy of ESAs, as iron is required for effective erythropoiesis. However, potential side effects of intravenous iron, such as allergic reactions or iron overload, require careful monitoring during treatment. In some cases, blood transfusions may be necessary, particularly in patients with severe anemia or those who do not respond adequately to ESA therapy and iron supplementation. Blood transfusions are typically reserved for patients with hemoglobin levels that are dangerously low or who are experiencing acute symptoms due to anemia, such as shortness of breath, chest pain, or dizziness. However, transfusions are not without risks, including the potential for transfusion reactions, infections, and an increased risk of iron overload, particularly in patients receiving repeated transfusions. In addition to these primary treatments, addressing the underlying causes of renal anemia is essential for effective management. Optimizing kidney function through the treatment of the underlying CKD, controlling blood pressure, managing diabetes, and reducing proteinuria can help mitigate the progression of renal anemia. Furthermore, addressing comorbid conditions such as cardiovascular disease, which is commonly seen in patients with CKD and renal anemia, is important for improving overall patient health. In conclusion, conventional treatment approaches for renal anemia focus on improving red blood cell production through the use of erythropoiesis-stimulating agents, replenishing iron stores with supplements or intravenous iron, and, when necessary, administering blood transfusions. These treatments, combined with the management of underlying conditions such as CKD, can significantly improve hemoglobin levels, reduce symptoms, and enhance the overall quality of life for patients with renal anemia. However, careful monitoring is essential to balance the benefits and potential risks of these treatments, ensuring optimal patient outcomes. Erythropoiesis-stimulating agents, ESAs. Erythropoiesis-stimulating agents, ESAs, have revolutionized the treatment of renal anemia, particularly in patients with chronic kidney disease, CKD, where the kidney's ability to produce erythropoietin is impaired. Erythropoietin is a hormone that stimulates the production of red blood cells in the bone marrow in response to low oxygen levels. When kidney function declines, erythropoietin production decreases, leading to anemia. ESAs work by mimicking the action of erythropoietin, thereby promoting red blood cell production and alleviating the symptoms of anemia, such as fatigue and shortness of breath. The two most commonly used ESAs in clinical practice are epoetin alpha and darbepoetin alpha. Both agents are recombinant forms of erythropoietin, with epoetin alpha being the original ESA developed for this purpose, and darbepoetin alpha being a longer-acting version. These medications are typically administered via subcutaneous or intravenous injection, with the choice of administration depending on the patient's specific needs and the healthcare setting. While both drugs are effective in stimulating red blood cell production, darbepoetin alpha has the advantage of a longer half-life, allowing for less frequent dosing, which can improve patient compliance and convenience. ESAs have been shown to significantly increase hemoglobin levels and reduce the need for blood transfusions in patients with renal anemia. By restoring red blood cell production, ESAs improve oxygen delivery to tissues and organs, thereby alleviating the symptoms of anemia and improving overall quality of life. For patients with advanced CKD or those on dialysis, ESAs can be a crucial part of their anemia management, as these patients are at higher risk of developing severe anemia due to their compromised kidney function. However, the use of ESAs requires careful monitoring to avoid potential complications. One of the most significant risks associated with ESA therapy is the potential for overcorrection of anemia, which can lead to adverse outcomes such as hypertension, thromboembolic events, and even increased mortality. Consequently, it is important to aim for a target hemoglobin range that is high enough to alleviate symptoms, but not so high as to increase the risk of cardiovascular events. Regular monitoring of hemoglobin levels and adjustment of ESA dosages are essential components of safe and effective treatment. Another concern with ESA therapy is the potential for iron deficiency. Since iron is essential for hemoglobin production, patients receiving ESAs may require iron supplementation to ensure that adequate iron is available for red blood cell production. Iron deficiency, whether absolute or functional, can impair the effectiveness of ESA therapy, and addressing it through oral or intravenous iron supplementation is a common part of the treatment regimen for renal anemia. In summary, erythropoiesis-stimulating agents are a cornerstone in the treatment of renal anemia, particularly in patients with chronic kidney disease. By stimulating red blood cell production, ESAs improve hemoglobin levels, reduce symptoms, and decrease the need for blood transfusions. However, their use must be carefully managed to avoid complications such as overcorrection of anemia, cardiovascular events, and iron deficiency. With appropriate monitoring and individualized dosing, ESAs can significantly enhance the quality of life and outcomes for patients with renal anemia. Iron supplementation strategies. Iron supplementation is a crucial component in the management of renal anemia, particularly in patients with chronic kidney disease, CKD. Iron is an essential mineral required for the production of hemoglobin, the protein in red blood cells that carries oxygen. In renal anemia, iron deficiency is common due to a variety of factors, including reduced dietary intake, impaired absorption, chronic inflammation, and blood loss. Effective iron supplementation strategies are essential to ensure that patients with renal anemia have adequate iron stores to support erythropoiesis and maximize the effectiveness of erythropoiesis-stimulating agents, ESAs. There are two primary forms of iron supplementation, oral and intravenous. Oral iron is typically the first-line treatment for iron deficiency in patients with renal anemia, as it is convenient and less invasive. Common oral iron preparations include ferrous sulfate, ferrous fumarate, and ferrous gluconate. These preparations are generally well tolerated, but gastrointestinal side effects such as nausea, constipation, and abdominal discomfort are common. In addition, the absorption of oral iron can be impaired in patients with advanced CKD, particularly those who are receiving medications that reduce stomach acid or those with gastrointestinal conditions such as gastric ulcers or irritable bowel syndrome. For patients who cannot tolerate oral iron or those with more severe iron deficiency, intravenous IV iron supplementation is often preferred. IV iron bypasses the gastrointestinal tract, providing more efficient replenishment of iron stores. Intravenous iron preparations, such as iron sucrose, ferric gluconate, and ferromoxetol, are typically administered in a healthcare setting under the supervision of a healthcare professional. IV iron has the advantage of higher bioavailability and can rapidly improve iron status, especially in patients with functional iron deficiency, a condition where iron is present in the body but not effectively utilized due to elevated hepcidin levels. The decision to use oral versus IV iron depends on several factors, including the severity of iron deficiency, the patient's tolerance of oral iron, and their response to previous treatments. Regular monitoring of iron parameters, including serum ferritin, transferrin saturation, and hemoglobin levels, is essential to guide treatment and ensure that iron supplementation is effective. While iron supplementation improves the efficacy of ESA therapy, it is also important to monitor for potential side effects, such as iron overload, which can occur with excessive IV iron administration. In conclusion, iron supplementation is a vital component of managing renal anemia, particularly for patients with CKD. Oral and intravenous iron strategies both have their advantages and limitations, and the choice of treatment should be tailored to the individual patient's needs. By ensuring adequate iron stores, clinicians can optimize the effectiveness of ESA therapy and improve overall patient outcomes. Blood transfusion, indications and risks. Blood transfusions are an important treatment option for patients with severe anemia, particularly when other therapies, such as erythropoiesis-stimulating agents, ESAs, and iron supplementation, are insufficient or inappropriate. In the context of renal anemia, blood transfusions are typically used when hemoglobin levels fall to dangerously low levels, leading to significant symptoms such as shortness of breath, fatigue, and dizziness. Additionally, transfusions are often necessary when patients experience acute or rapid blood loss, which can occur due to surgery, gastrointestinal bleeding, or dialysis procedures. The primary indication for blood transfusion in renal anemia is to quickly restore oxygen carrying capacity and alleviate symptoms of severe anemia. In patients with chronic kidney disease, CKD, especially those on dialysis, blood transfusions may be used to manage anemia when there is insufficient response to ESAs and iron therapy or when iron overload is a concern. Transfusions are also considered in situations where anemia is affecting the patient's quality of life, especially if they are unable to perform daily activities or have a significant decline in their functional status due to anemia. However, while blood transfusions can be life-saving and help stabilize patients with renal anemia, they are not without risks. One of the primary concerns is the potential for transfusion reactions, which can range from mild to severe. Common mild reactions include fever, chills, and rash, while more serious reactions, such as allergic or hemolytic transfusion reactions, can lead to life-threatening conditions. Another risk associated with blood transfusions is the transmission of infections, although this risk has decreased significantly due to improvements in screening and blood safety protocols. Iron overload is another significant risk in patients who require frequent blood transfusions. Red blood cells contain a large amount of iron, and repeated transfusions can lead to an accumulation of iron in tissues such as the liver, heart, and endocrine glands. This can result in organ dysfunction and may require chelation therapy to remove excess iron from the body. In summary, blood transfusions play a vital role in managing severe renal anemia, especially in cases where other treatments are ineffective or contraindicated. However, careful consideration of the risks, including transfusion reactions, infection transmission, and iron overload, is essential when deciding whether blood transfusion is appropriate for a particular patient. Monitoring and preventive measures, such as iron chelation therapy and appropriate screening, can help mitigate some of these risks. Chapter 6: Advanced and Emerging Therapies. As the understanding of renal anemia and its underlying mechanisms continues to evolve, so too do the therapeutic options available for patients with this condition. While conventional treatments such as erythropoiesis-stimulating agents, ESAs, and iron supplementation have been standard for many years, advanced and emerging therapies offer promising new avenues for managing renal anemia, particularly in patients with chronic kidney disease, CKD, who may not respond adequately to traditional approaches. One of the most significant advancements in the treatment of renal anemia has been the development of hypoxia-inducible factor, HIF, prolyl hydroxylase inhibitors. These oral medications, such as roxadustat, vadadustat, and daprodustat, work by mimicking the body's response to low oxygen levels, stimulating the production of erythropoietin in the kidneys. Unlike ESAs, which directly provide erythropoietin, HIF prolyl hydroxylase inhibitors activate the body's natural erythropoiesis process by stabilizing HIFs, which in turn increase the production of both erythropoietin and red blood cells. These drugs have shown promising results in clinical trials, improving hemoglobin levels in CKD patients with anemia, and potentially offering a more convenient oral alternative to traditional injectable therapies. Additionally, because they work through a different mechanism, they may have a lower risk of some of the adverse effects associated with ESAs, such as hypertension and thromboembolic events. Another emerging therapy for renal anemia is the use of novel iron formulations. While intravenous IV iron supplementation has been a standard treatment for iron deficiency in patients with CKD, new iron agents, such as ferric diisomaltose and ferric carboxymaltose, offer more efficient delivery of iron with fewer side effects. These newer agents allow for the administration of higher doses of iron in a shorter period, reducing the frequency of infusions and improving patient adherence to treatment. These iron formulations are particularly beneficial for patients who have functional iron deficiency, where iron is present but is not effectively utilized due to elevated hepcidin levels. These new agents are being studied to ensure their safety and long-term efficacy in managing renal anemia. In addition to pharmacologic interventions, advances in personalized medicine and precision treatment approaches are beginning to shape the management of renal anemia. By integrating genetic testing, biomarkers, and patient-specific factors, clinicians can tailor treatment strategies to each patient's unique needs, optimizing therapeutic outcomes. This personalized approach may include choosing the right combination of ESA, iron supplementation, and emerging therapies, as well as adjusting dosages based on individual responses. In conclusion, advanced and emerging therapies for renal anemia are providing new options for patients with CKD. HIF prolyl hydroxylase inhibitors, novel iron formulations, and personalized treatment strategies represent the future of anemia management, offering the potential for more effective, safer, and individualized care. As research continues, these therapies are likely to become integral components of the treatment landscape, further improving the quality of life and outcomes for patients with renal anemia. Hypoxia-inducible factor prolyl hydroxylase inhibitors, HIF-5s. Hypoxia-inducible factor prolyl hydroxylase inhibitors, HIF-5s, represent a novel and promising class of oral medications in the treatment of renal anemia, particularly for patients with chronic kidney disease, CKD. These drugs, including roxadustat, vadadustat, and daprodustat, work by mimicking the body's natural response to low oxygen levels, a process that is crucial for regulating red blood cell production. Under normal conditions, the body's response to hypoxia, or low oxygen levels, is to increase the production of erythropoietin, EPO, in the kidneys. EPO then stimulates the bone marrow to produce red blood cells, helping to restore oxygen carrying capacity. HIF-5s act by inhibiting prolyl hydroxylase enzymes, which are responsible for degrading hypoxia-inducible factors, HIFs, under normal oxygen conditions. By inhibiting these enzymes, HIF-5s stabilize HIFs, which in turn promote the transcription of EPO and other genes involved in erythropoiesis, the production of red blood cells. This results in an increase in erythropoietin levels and red blood cell production, addressing the anemia that is often seen in CKD patients. One of the key advantages of HIF-5s over traditional erythropoiesis-stimulating agents, ESAs, is their ability to act in a more physiological manner. While ESAs directly provide erythropoietin, HIF-5s stimulate the body's own natural erythropoiesis mechanisms. This may offer a more targeted approach to anemia management with potentially fewer side effects, such as hypertension and thromboembolic events, which are sometimes associated with ESA therapy. Additionally, HIF-5s are administered orally, offering a more convenient option compared to the injections required for ESA therapy. Clinical trials have shown that HIF-5s are effective in increasing hemoglobin levels and reducing the need for blood transfusions in CKD patients with anemia. These drugs are particularly beneficial for patients who experience inadequate responses to ESA therapy or those who are unable to tolerate ESAs. Furthermore, because HIF-5s promote red blood cell production through a natural oxygen-sensing pathway, they may also have a more favorable effect on iron utilization compared to ESAs. However, while promising, the use of HIF-5s requires careful monitoring. As with any treatment, there are potential risks, including the possibility of elevated blood pressure and thromboembolic events. Ongoing studies are needed to further assess the long-term safety and efficacy of these drugs, particularly in diverse patient populations. In summary, HIF-5s are an innovative and effective treatment option for renal anemia in CKD patients. By mimicking the body's natural response to hypoxia, they stimulate erythropoiesis and offer an alternative to traditional ESA therapy, with the potential for fewer side effects and more convenient oral administration. As research continues, these therapies may become an essential part of managing anemia in CKD patients, improving outcomes and quality of life. Gene therapy and experimental treatments. Gene therapy and experimental treatments represent the frontier of innovation in the management of renal anemia, offering potential solutions for patients with chronic kidney disease, CKD, whose anemia is difficult to manage with traditional therapies. These approaches aim to address the underlying causes of renal anemia at the genetic and molecular levels, providing the opportunity for more effective, long-lasting solutions. Gene therapy involves the introduction, alteration, or removal of genetic material within a patient's cells to treat or prevent disease. In the context of renal anemia, gene therapy could potentially address the reduced production of erythropoietin, EPO, in the kidneys, a hallmark of the condition. By delivering a functional copy of the EPO gene to kidney cells or other relevant tissues, gene therapy could restore natural erythropoietin production, thereby stimulating red blood cell production in a manner similar to how the body responds to low oxygen levels. While still in the experimental phase, this approach has shown promise in animal models, and ongoing research is exploring its feasibility in human clinical trials. One of the challenges of gene therapy is ensuring safe and efficient delivery of genetic material to the appropriate cells, which requires advanced techniques such as viral vectors or nanoparticle-based delivery systems. Additionally, long-term safety concerns, such as immune reactions and off-target effects, need to be carefully studied and addressed. Alongside gene therapy, other experimental treatments are being investigated to improve the management of renal anemia. One such approach is the use of small molecules and biologics that target specific pathways involved in erythropoiesis regulation. For instance, inhibiting certain factors that suppress erythropoietin production could help stimulate red blood cell production in patients with CKD. Additionally, therapies targeting the inflammatory pathways that contribute to anemia in CKD are being explored, as inflammation often disrupts the normal functioning of erythropoiesis and iron metabolism. Advancements in stem cell therapy are also being explored for the treatment of renal anemia. Stem cells, particularly hematopoietic stem cells, have the potential to regenerate damaged tissues and restore normal blood cell production. By harnessing the regenerative capabilities of stem cells, researchers hope to develop treatments that not only address anemia, but also improve kidney function in CKD patients. In conclusion, gene therapy and experimental treatments hold significant promise for the future management of renal anemia, offering the potential for more personalized, effective, and durable solutions. While these therapies are still in the early stages of development, they represent a new frontier in the quest to improve outcomes for patients with renal anemia and chronic kidney disease. Personalized medicine in renal anemia. Personalized medicine is an evolving approach to healthcare that tailors treatment to individual patients based on their unique genetic, environmental, and lifestyle factors. In the context of renal anemia, personalized medicine has the potential to optimize treatment strategies, improving patient outcomes by targeting the specific mechanisms underlying their condition. By considering factors such as genetic predisposition, kidney function, comorbidities, and response to previous treatments, personalized approaches can offer more effective and safer therapies for individuals with chronic kidney disease, CKD, and anemia. One of the key aspects of personalized medicine in renal anemia is the use of genetic and biomarker testing to guide treatment decisions. For instance, genetic variants that influence erythropoietin, EPO production, or iron metabolism may help determine which therapies are most likely to be effective for a particular patient. By analyzing these genetic markers, clinicians can predict how a patient will respond to erythropoiesis-stimulating agents, ESAs, iron supplementation, or newer treatments like hypoxia-inducible factor prolyl hydroxylase inhibitors, HIFIs. This allows for a more tailored approach to therapy, reducing trial and error treatment and improving outcomes. Biomarkers, such as serum ferritin and transferrin saturation, also play a critical role in personalized medicine for renal anemia. By monitoring these markers, healthcare providers can assess a patient's iron status and determine whether they have sufficient iron stores to support erythropoiesis. In cases of functional iron deficiency, where iron is present but not effectively utilized, personalized treatment with novel iron formulations or alternative therapies may be required to address the underlying issue. Additionally, personalized medicine can help address the individual patient's comorbidities, such as hypertension or diabetes, which may influence the development or progression of renal anemia. For example, some patients may have elevated hepcidin levels, an inflammatory marker that blocks iron absorption and utilization. By identifying these factors, clinicians can modify treatment plans to better suit the patient's specific needs, improving both anemia management and overall kidney health. The goal of personalized medicine in renal anemia is to improve patient quality of life by providing therapies that are not only more effective, but also safer. By focusing on the patient as an individual, treatment plans can be optimized to minimize side effects, reduce hospitalizations, and avoid unnecessary interventions, such as blood transfusions. While personalized medicine in renal anemia is still in its early stages, ongoing research and advances in genomics and biomarker identification are likely to make it an integral part of clinical practice in the near future. In conclusion, Personalized medicine represents the future of renal anemia treatment, offering the potential for tailored, more effective therapies that address the specific needs of individual patients. By leveraging genetic testing, biomarkers, and a patient-centered approach, clinicians can optimize treatment and improve outcomes for those living with CKD-related anemia. Chapter 7. Management in Special Populations. Managing renal anemia in special populations requires a tailored approach due to the unique physiological, medical, and pharmacological factors that may affect treatment outcomes. Populations such as the elderly, pregnant women, pediatric patients, and those with coexisting conditions, such as diabetes or cardiovascular disease, necessitate careful consideration to ensure effective and safe management of anemia in the context of chronic kidney disease, CKD. In elderly patients, renal anemia is often compounded by age-related declines in kidney function and comorbid conditions. These patients may have a diminished response to erythropoiesis-stimulating agents, ESAs, and are at a higher risk for side effects such as hypertension, fluid retention, and thrombosis. Therefore, treatment strategies in this group should focus on cautious dose adjustments of ESAs and iron supplementation, along with close monitoring of blood pressure and renal function. Additionally, the risk of polypharmacy and drug interactions in the elderly necessitates regular review of all medications to avoid adverse effects. Pregnant women with CKD face additional challenges in managing anemia. Pregnancy induces physiological changes that can exacerbate kidney disease and anemia, such as increased plasma volume and altered iron metabolism. The use of ESAs in pregnancy remains controversial, as it may have potential risks for both the mother and fetus. Consequently, iron supplementation is often prioritized, and non-ESA therapies are preferred unless the anemia is severe. Close monitoring of both maternal and fetal health is critical, with interdisciplinary care involving nephrologists, obstetricians, and hematologists to ensure the best possible outcomes. Pediatric patients with renal anemia also require specialized management, as their anemia may be related to congenital kidney disorders or conditions that are specific to childhood, such as nephrotic syndrome. Children with CKD often have unique responses to ESA therapy and iron supplementation, with dosing adjustments based on weight and growth patterns. In this population, careful monitoring of growth, development, and potential side effects is essential. Moreover, long-term management strategies must consider the potential impact on the child's cognitive and physical development, as well as the psychological and social aspects of managing a chronic illness during childhood. In patients with comorbid conditions, such as diabetes or cardiovascular disease, managing renal anemia requires a comprehensive approach that addresses the interrelationship between these conditions and CKD. For example, diabetes may exacerbate kidney damage, while cardiovascular disease increases the risk of complications from anemia, such as heart failure or ischemic events. A multidisciplinary approach, including glycemic control and cardiovascular risk management, is essential to optimize anemia treatment while managing these overlapping conditions. In conclusion, managing renal anemia in special populations requires individualized care plans that account for age, pregnancy, childhood development, and comorbidities. By addressing the unique challenges and risks in these groups, healthcare providers can ensure that anemia is treated effectively while minimizing potential complications and improving overall quality of life. Pediatric patients. Managing renal anemia in pediatric patients with chronic kidney disease, CKD, presents unique challenges that require a tailored approach to treatment. Children with CKD, particularly those with congenital or acquired kidney disorders, often experience anemia due to a variety of factors, including reduced erythropoietin production, iron deficiency, and the inflammatory effects of kidney disease. Given that pediatric patients are still growing and developing, their treatment needs differ significantly from those of adults, making careful monitoring and individualized care essential. One of the primary concerns when managing renal anemia in children is determining the appropriate dosing of erythropoiesis-stimulating agents, ESAs, and iron supplements. Children's bodies process medications differently than adults, and their growth patterns must be taken into account when adjusting doses. ESAs are commonly used to stimulate red blood cell production, but dosing must be done cautiously to avoid complications such as hypertension, which can occur with higher ESA doses. Furthermore, pediatric patients may require more frequent monitoring of their hemoglobin levels, as their response to ESA therapy can vary. Iron supplementation is another key aspect of managing anemia in children with CKD. Inadequate iron stores are a common problem, especially in those with functional iron deficiency, where iron is present but not effectively utilized due to elevated hepcidin levels. Pediatric patients often need intravenous (IV) iron infusions rather than oral iron supplements due to absorption challenges in their gastrointestinal systems. The risk of iron overload must also be considered, as children with CKD are more prone to excessive iron accumulation, which can have detrimental effects on various organs. Another important consideration in managing renal anemia in pediatric patients is the long-term impact on growth and development. Anemia in children can lead to fatigue, poor appetite, and impaired cognitive and physical development. It is crucial that anemia management not only focuses on improving hemoglobin levels, but also on supporting the child's overall well-being and growth trajectory. This requires a multidisciplinary approach involving nephrologists, pediatricians, dietitians, and hematologists to ensure comprehensive care. Finally, psychological and social factors must be taken into account when treating pediatric patients with CKD-related anemia. Children with chronic conditions often experience emotional challenges, including anxiety and depression, and may struggle with school attendance or social interactions due to fatigue and other symptoms of anemia. Addressing these issues through counseling and support groups, as well as involving parents and caregivers in the treatment process, can help improve the child's quality of life. In conclusion, managing renal anemia in pediatric patients requires a careful, individualized approach that considers the child's unique physiological needs, growth and development, and psychosocial factors. By providing targeted treatments and offering holistic care, healthcare providers can help optimize the outcomes and well-being of children with CKD and anemia. Elderly and frail individuals. Managing renal anemia in elderly and frail individuals requires careful consideration of both the physiological changes associated with aging and the complexities of comorbidities commonly seen in this population. Chronic kidney disease, CKD, is prevalent in older adults, and renal anemia often develops as a consequence of decreased erythropoietin production, impaired iron metabolism, and inflammation. However, treatment in the elderly requires a nuanced approach, balancing the need to correct anemia while minimizing the risks of adverse effects from therapies. One of the main challenges in managing renal anemia in older adults is the increased risk of cardiovascular complications. Anemia in the elderly, particularly in those with CKD, can exacerbate pre-existing heart conditions such as heart failure, ischemic heart disease, or hypertension. For this reason, the use of erythropoiesis-stimulating agents, ESAs, must be done cautiously, as excessive dosing can lead to hypertension, fluid overload, and thrombotic events. Elderly patients may also have a diminished response to ESAs, necessitating careful titration and close monitoring of hemoglobin levels. In some cases, intravenous iron supplementation is required, but iron overload must be monitored to avoid complications such as organ damage. In frail individuals, the risks of treatment intensify due to reduced organ reserve, polypharmacy, and the presence of multiple comorbidities. The frailty syndrome often includes physical weakness, cognitive decline, and reduced mobility, all of which can impact a patient's ability to adhere to treatment regimens. Additionally, these individuals may experience more pronounced side effects from medications due to reduced renal clearance and changes in drug metabolism. The choice of anemia therapy must take into account the patient's overall health status, frailty score, and ability to tolerate certain interventions. Oral iron supplementation may be less effective in this group due to impaired gastrointestinal absorption, leading to a preference for intravenous iron administration in many cases. Another important consideration is the potential for adverse drug interactions. Older adults are often on multiple medications for comorbid conditions such as diabetes, hypertension, and cardiovascular disease. Careful management and coordination of these medications are essential to avoid negative interactions that could worsen anemia or interfere with treatment effectiveness. Finally, the psychological and social aspects of treating elderly and frail individuals with renal anemia should not be overlooked. These patients may face challenges such as depression, social isolation, and cognitive impairment, which can complicate their response to treatment and overall quality of life. A holistic patient-centered approach, which involves caregivers and family members, is essential to ensure that treatment plans are practical and sustainable. In conclusion, managing renal anemia in elderly and frail individuals requires a delicate balance between correcting anemia and minimizing treatment risks. By tailoring treatment strategies to the individual's health status, comorbidities, and preferences, healthcare providers can improve outcomes and quality of life for this vulnerable population. Patients on dialysis. Managing renal anemia in patients on dialysis presents unique challenges due to the complex interplay between kidney failure, anemia, and the dialysis process itself. Anemia is a common and often debilitating complication in dialysis patients, primarily caused by insufficient erythropoietin production by the kidneys, along with factors like iron deficiency, blood loss during dialysis, and chronic inflammation. Addressing anemia in this population requires careful consideration of both the underlying kidney disease and the effects of dialysis treatments. One of the primary strategies for managing renal anemia in dialysis patients is the use of erythropoiesis-stimulating agents, ESAs, which help stimulate red blood cell production. However, the response to ESAs in dialysis patients can be variable, and higher doses are often needed compared to non-dialysis patients. Despite ESA therapy, these patients may still struggle with anemia due to factors such as inadequate iron stores, poor response to ESAs, or ongoing blood loss during dialysis. This makes iron supplementation a key component of treatment. Intravenous iron is typically preferred over oral iron, as it is more effectively utilized in dialysis patients, and it helps optimize erythropoiesis. Regular monitoring of ferritin levels and transferrin saturation is crucial to prevent iron overload, which can cause adverse effects like cardiovascular events or organ damage. Dialysis itself contributes to anemia in several ways. During hemodialysis, small amounts of blood are lost through the dialysis filter, leading to a gradual reduction in red blood cell count. Additionally, the process of dialysis may lead to the removal of certain nutrients and hormones, further contributing to anemia. Peritoneal dialysis can also have a similar impact, although the loss of blood through the peritoneum is generally less significant. Managing blood loss, whether during dialysis or as a result of other factors like gastrointestinal bleeding, is essential to prevent worsening anemia in these patients. Furthermore, the presence of chronic inflammation, often seen in dialysis patients, can reduce the body's ability to use iron effectively and impair erythropoiesis. Elevated levels of pro-inflammatory cytokines, such as interleukin-6, Illinois-6, can inhibit erythropoietin production and iron utilization, making anemia more difficult to manage. Addressing the underlying inflammation through medications or dietary modifications can help improve anemia control in dialysis patients. In conclusion, Managing renal anemia in patients on dialysis requires a comprehensive approach that includes the use of ESAs, iron supplementation, and monitoring for blood loss and inflammation. Due to the complexities of dialysis therapy and the various factors that contribute to anemia in this population, individualized treatment plans are essential for optimizing patient outcomes and improving quality of life. Chapter 8: Multidisciplinary Care and Patient Education. Effective management of renal anemia requires a holistic approach that goes beyond medical interventions. Multidisciplinary care and patient education play a crucial role in improving outcomes for individuals with chronic kidney disease, CKD, and anemia. These components ensure that patients receive comprehensive care, addressing both the physiological and psychosocial aspects of their condition, while also empowering them to actively participate in their own treatment plan. Multidisciplinary care involves a team of healthcare providers from various specialties who collaborate to address the complex needs of patients with renal anemia. Nephrologists, hematologists, dietitians, nurses, social workers, and other specialists work together to develop and implement individualized care plans. This approach ensures that all aspects of the patient's condition are addressed, including kidney function, anemia management, comorbid conditions, and overall quality of life. For instance, nephrologists oversee the management of CKD, while hematologists may guide the appropriate use of erythropoiesis-stimulating agents, ESAs, and iron supplementation. Dietitians provide guidance on nutrition, focusing on iron-rich foods and managing other dietary needs specific to CKD. Nurses are critical in monitoring patients during treatment and providing education on self-care. Additionally, social workers help address the emotional and psychological challenges faced by patients with chronic conditions. These may include anxiety, depression, or the stress of managing a chronic illness. A multidisciplinary approach ensures that patients receive the support they need, not only physically, but also emotionally and mentally, enhancing overall well-being and treatment adherence. Patient education is another fundamental aspect of effective renal anemia management. Educating patients about their condition, treatment options, and the importance of adherence to prescribed therapies can significantly improve outcomes. For instance, patients need to understand the role of erythropoiesis-stimulating agents and iron supplements in managing anemia, as well as the potential side effects and how to manage them. Education should also cover lifestyle modifications, such as dietary changes to improve iron intake, and maintaining a healthy lifestyle to manage comorbidities like hypertension and diabetes. Moreover, educating patients about the importance of regular monitoring and follow-up appointments helps ensure that any changes in their condition are detected early, allowing for timely adjustments to their treatment plan. Informed patients are more likely to be engaged in their care, leading to better treatment adherence and improved overall health outcomes. In conclusion, a multidisciplinary approach to managing renal anemia, combined with comprehensive patient education, is essential for optimizing care and improving the quality of life for individuals with CKD. By fostering collaboration among healthcare providers and empowering patients with knowledge, renal anemia can be managed more effectively, leading to better clinical outcomes and enhanced patient satisfaction. Role of the healthcare team. The management of renal anemia requires a coordinated effort from a diverse healthcare team to ensure comprehensive care for patients with chronic kidney disease, CKD. Each member of the team plays a vital role in addressing the multifaceted challenges associated with renal anemia, from diagnosing the condition to implementing treatment strategies and providing ongoing support. The healthcare team works together to optimize patient outcomes, manage comorbidities, and promote overall well-being. At the forefront of this team are nephrologists, who are primarily responsible for the management of CKD and the associated renal anemia. Nephrologists diagnose anemia, determine its underlying causes, and prescribe appropriate treatments, including erythropoiesis-stimulating agents, ESAs, and iron supplementation. They monitor kidney function, assess the progression of CKD, and adjust treatment plans as necessary. The nephrologist also coordinates with other specialists to ensure that comorbidities such as hypertension, diabetes, and cardiovascular disease are adequately addressed, as these conditions can complicate anemia management. Hematologists play an important role in the management of renal anemia, particularly when it comes to the use of ESAs. They provide guidance on the appropriate use of these medications and help manage any side effects or complications that may arise, such as iron overload or hypertension. Hematologists also assist in distinguishing renal anemia from other types of anemia, ensuring accurate diagnosis and treatment. Dietitians are crucial in managing anemia in CKD patients, as proper nutrition can play a significant role in both the prevention and treatment of anemia. They assess the patient's dietary habits and provide recommendations on iron-rich foods and supplements, as well as strategies to optimize iron absorption. Dietitians also help manage other aspects of nutrition, such as controlling potassium and phosphorus intake, which are particularly important for patients with CKD. Nurses are essential members of the healthcare team, providing direct patient care, administering treatments, and educating patients on self-management strategies. Nurses help monitor patients' response to treatment, including tracking hemoglobin levels, managing side effects, and ensuring proper administration of medications such as ESAs and iron supplements. They also provide valuable support in educating patients about their condition and treatment regimen, which is critical for improving treatment adherence. Social workers and psychologists are integral to supporting patients emotionally and psychologically. Chronic kidney disease and anemia can have a significant impact on a patient's mental health, leading to feelings of anxiety, depression, or isolation. Social workers can help patients navigate the healthcare system, address social determinants of health, and connect them with community resources. Psychologists or counselors provide support in managing the emotional challenges of living with a chronic illness, improving patients' overall well-being. In conclusion, managing renal anemia in patients with CKD is a team effort that requires collaboration between nephrologists, hematologists, dietitians, nurses, and mental health professionals. Each member of the healthcare team brings unique expertise, and together, they provide holistic care that addresses not only the physical aspects of anemia, but also the emotional, social, and nutritional needs of the patient. This collaborative approach ensures the best possible outcomes for patients living with renal anemia. Patient engagement and self-management. Patient engagement and self-management are pivotal in the effective treatment of renal anemia, especially for individuals with chronic kidney disease, CKD. These two components not only empower patients to take an active role in their care, but also improve treatment adherence, clinical outcomes, and quality of life. By actively involving patients in managing their condition, healthcare providers can ensure a more holistic and sustainable approach to managing renal anemia. Patient engagement refers to the process by which individuals are encouraged to become active participants in their healthcare. This involves understanding the nature of their condition, recognizing the importance of treatment, and being motivated to follow the prescribed plan. In the context of renal anemia, engagement means that patients comprehend how anemia is related to their CKD and the role of therapies like erythropoiesis-stimulating agents, ESAs, iron supplementation, and dietary changes. An engaged patient is more likely to adhere to prescribed treatments and make necessary lifestyle adjustments, which directly impacts their health outcomes. Education is the cornerstone of patient engagement. When patients understand the reasons behind their treatment, they are more likely to feel motivated to participate in their care. Educating patients about the risks of untreated anemia, including fatigue, cardiovascular complications, and poor quality of life, can encourage them to adhere to treatment plans. Additionally, Providing information on how anemia is managed through medications, diet, and regular monitoring helps demystify the process and reduces anxiety surrounding the treatment. Self-management, on the other hand, involves the patient taking responsibility for day-to-day aspects of their health. In the case of renal anemia, this includes adhering to medication regimens, managing iron levels, maintaining proper nutrition, and regularly monitoring their health status. Encouraging self-management helps patients develop a sense of control over their condition, reducing dependency on healthcare providers for every aspect of care. For example, patients may need to track their iron intake and recognize the signs of anemia, such as increased fatigue or weakness, to alert their healthcare team early when adjustments are needed. The support of the healthcare team is crucial in facilitating both engagement and self-management. Regular follow-ups, where patients can ask questions, address concerns, and receive encouragement, are key to maintaining their involvement in the treatment process. Furthermore, tools such as mobile apps or patient portals can be used to track medication adherence, monitor vital signs, and provide educational resources, making it easier for patients to manage their condition. In conclusion, patient engagement and self-management are essential elements in the effective treatment of renal anemia. By empowering patients with knowledge, tools, and the support of their healthcare team, they can better manage their condition and improve their health outcomes. Ultimately, this collaborative approach fosters a sense of ownership and confidence in managing renal anemia, leading to better overall care. Nutrition and lifestyle interventions. Nutrition and lifestyle interventions play a critical role in managing renal anemia, especially for individuals with chronic kidney disease, CKD. Proper dietary choices and lifestyle adjustments can complement medical treatments and help mitigate the effects of anemia. For patients with CKD, these interventions are key to managing both the underlying kidney disease and its complications, including anemia. A well-balanced diet is essential for maintaining optimal health and supporting erythropoiesis, the process of red blood cell production. Iron-rich foods such as lean meats, beans, lentils, spinach, and fortified cereals are particularly important for patients with renal anemia. Iron is crucial for the production of hemoglobin, the protein in red blood cells that carries oxygen throughout the body. However, for CKD patients, it is essential to balance iron intake with proper kidney function. While iron supplementation is often necessary, dietary intake can also play a role in preventing or mitigating iron deficiency. In addition to iron, other nutrients are important for managing anemia. Vitamin B12 and folate are essential for red blood cell production and maturation. Foods rich in these vitamins, such as eggs, dairy products, leafy greens, and fortified grains, should be included in the diet. However, it's important to monitor vitamin B12 and folate levels carefully, as excessive intake of certain vitamins can sometimes exacerbate other kidney-related issues. Limiting potassium, phosphorus, and sodium intake is another critical aspect of nutrition for patients with CKD. High levels of potassium and phosphorus can lead to complications, including arrhythmias and bone disease. A diet low in processed foods and rich in fruits, vegetables, and whole grains, while avoiding excessive amounts of high potassium and high phosphorus foods, can help maintain optimal electrolyte balance and kidney function. Alongside nutrition, lifestyle interventions such as regular physical activity, smoking cessation, and stress management can improve overall health and reduce the impact of anemia. Physical activity is beneficial for improving cardiovascular health and maintaining healthy red blood cell production. Moderate exercises, such as walking or swimming, can help alleviate fatigue and improve energy levels, which is a common symptom of anemia. Smoking cessation is another important lifestyle change for patients with CKD and anemia. Smoking exacerbates cardiovascular problems and can worsen kidney function, thereby compounding the effects of anemia. Encouraging patients to quit smoking can help improve both kidney health and overall well-being. Finally, managing stress and ensuring adequate sleep are often overlooked but essential components of a healthy lifestyle. Chronic stress can exacerbate inflammation and negatively impact both kidney function and anemia. Ensuring proper sleep can help with energy levels, immune function, and overall recovery. In conclusion, nutrition and lifestyle interventions are fundamental in managing renal anemia. A balanced diet rich in essential nutrients, along with regular physical activity and healthy lifestyle choices, can significantly improve outcomes for patients with CKD. By addressing both the physiological and behavioral aspects of care, patients can better manage anemia and enhance their quality of life. Conclusion. Renal anemia, a common and often under-recognized complication of chronic kidney disease, CKD, requires a multifaceted approach for effective management. From understanding the underlying mechanisms to exploring diagnostic tools, treatment strategies, and patient care, addressing renal anemia demands collaboration across various healthcare specialties. The importance of a comprehensive treatment plan that integrates medical interventions, patient education, lifestyle modifications, and continuous monitoring cannot be overstated. The pathophysiology of renal anemia revolves primarily around the kidney's inability to produce sufficient erythropoietin, a hormone essential for red blood cell production. This, combined with factors such as iron deficiency, inflammation, and the effects of uremic toxins, leads to the development of anemia. As renal function declines, anemia becomes more pronounced, further exacerbating the symptoms of CKD, including fatigue, weakness, and decreased quality of life. Thus, timely diagnosis and appropriate management are critical in improving patient outcomes. Conventional treatments, such as erythropoiesis-stimulating agents, ESAs, and iron supplementation, have been the cornerstone of renal anemia management. These therapies help stimulate red blood cell production and replenish iron stores, respectively. However, emerging therapies, such as hypoxia-inducible factor prolyl hydroxylase inhibitors, HIF-5s, and gene therapy, are offering promising new avenues for more targeted and effective treatments, particularly for patients who do not respond well to conventional therapies. These advances in treatment underscore the dynamic nature of renal anemia management and the importance of staying informed about new developments in the field. Equally important is the role of a multidisciplinary healthcare team. Nephrologists, hematologists, dietitians, nurses, and other healthcare professionals collaborate to provide personalized care tailored to each patient's unique needs. This holistic approach, which includes managing comorbid conditions, educating patients, and promoting self-management, leads to better outcomes. Patients who are actively involved in their care and understand the importance of lifestyle changes, such as dietary adjustments and physical activity, are more likely to experience improved quality of life and better health outcomes. Furthermore, managing renal anemia in special populations, such as pediatric patients, the elderly, and individuals on dialysis, requires specialized attention. Each of these groups may face unique challenges, including differing responses to treatment, comorbidities, and lifestyle factors. Tailored strategies are essential to ensure that all patients, regardless of age or stage of disease, receive optimal care. In conclusion, renal anemia is a complex condition that requires a comprehensive, patient-centered approach to treatment. Through advancements in therapies, enhanced patient engagement, and a collaborative healthcare team, it is possible to improve the lives of those affected by renal anemia and CKD. Continued research, education, and multidisciplinary care will be the driving forces in further optimizing management strategies and improving outcomes for these patients.